Hello, and welcome to the workshop, Heart and Vascular Health After Transplant. My name is Lynn Spina, and I will be your moderator for this workshop. It is my pleasure to introduce today's speaker, Dr. Michael Fradley. Dr. Fradley is an attending cardiologist, electrophysiologist, and an associate professor of clinical medicine in the Division of Cardiology at the Perelman School of Medicine at the University of Pennsylvania. He serves as both the section chief of the Consultative Cardiology section and the medical director of the Thalheimer Center for Cardio-Oncology at the University of Pennsylvania. As a trained electrophysiologist, Dr. Fradley has a particular interest in the diagnosis and management of arrhythmic complications associated with traditional and novel cancer therapies. He has published more than 90 manuscripts, and he has served as the co-chair of the Global Cardio-Oncology Summit in both 2018 and 2021. Please join me in welcoming Dr. Fradley.
Well, thank you, and good morning. I want to start off by thanking Marla, Sue, Lynn, and all the organizers for inviting me to give this talk today about cardiovascular risk associated with stem cell transplantation. So, as you know, my name is Mike Fradley, and as the introduction suggested, I'm a cardio-oncologist at the University of Pennsylvania, as well as an electrophysiologist. And you might be wondering, what is a cardio-oncologist and what is an electrophysiologist? Well, a cardio-oncologist is a cardiologist who specializes in the management of cardiovascular disease and risk in cancer patients and cancer survivors. And an electrophysiologist happens to be another subspecialty of cardiology that focuses on abnormal heart rhythms. So we're the doctors that will manage someone with atrial fibrillation. We are the ones that put in pacemakers. And I think that you're going to see from this talk that stem cell transplant survivors must be very mindful of their cardiovascular health. So these are my disclosures. And I wanted to start off by providing you with a roadmap for my presentation. So first, I'm going to review some of the short and long-term cardiovascular toxicities that can develop post-stem cell transplantation. And then I want to highlight some cardiovascular risk mitigation strategies for survivors. Now, cardiovascular disease and cancer are the two most common causes of mortality in the United States. About 1 in 3 Americans have some form of cardiovascular disease. There are also around 12 million patients who have active cancer. What you may not realize is now there are more than 14 million cancer survivors, with that number expected to increase dramatically over the next decade. About 30% of patients who receive cancer therapies will develop some type of cardiac complication. And this may be a new problem or the exacerbation of underlying pre-existing disease. And these cardiotoxicities can affect a patient's survival as well as their quality of life, independent of their oncologic prognosis. And some of these complications may not become apparent for many years after the completion of treatments. And it's become increasingly important to monitor for and treat these cardiovascular complications because patients with cancer are living longer and in many cases surviving their disease. And you can see from this chart the 5-year survival rates for many cancers has increased significantly over the last 3 decades, with some approaching 100%. And some cancers are now even being managed as chronic diseases. So the last thing we want is for cardiovascular disease to become a barrier to receiving effective cancer therapy or to survive cancer only to be left with lifelong debilitating cardiovascular disease. Now we know from that cardiovascular disease is common after cancer treatment in general. These are data from the Childhood Cancer Survivor Study out of St. Jude's Research Hospital. And they looked at more than 10,000 adult survivors of a pediatric cancer and compared them to 3,100 siblings. And this was an attempt to control as best as possible for things like genetics or other environmental factors and exposures. And what they found was by the age of 45, coronary artery disease, valvular disease, abnormal heart rhythms, and heart failure were significantly increased in the survivors compared to their siblings. And when you look at serious life-threatening events, the incidence was at around 5.3%. Now, when you consider complications post-stem cell transplant, it's important to recognize that cardiovascular issues account for only around 10% or less of all post-transplant related complications. So when you all are thinking about the various issues that can occur post-transplant, cardiovascular complications are not the predominant issue. But if a cardiovascular complication occurs, it can be associated with a high mortality rate and decreased quality of life for long-term survivors. And at 25 years post-transplant, approximately 22% will experience some sort of a cardiovascular event. And therefore, it's essential to try to reduce cardiovascular risk in transplant survivors. Now, cardiovascular events post-transplant are related to multiple factors, including the exposure to anthracyclines, which are a common chemotherapy given prior to transplant for various different malignancies, the exposure to radiation, especially if it's directed to the chest, exposure to various targeted therapies or immunotherapies, which are becoming increasingly more utilized for the management of these diseases, exposure to high-dose cyclophosphamide, which is often a part of the preconditioning regimens for transplant, the development of graft versus host disease, as well as the presence of baseline cardiovascular disease and risk factors when a patient is going into transplant, things like hypertension or diabetes. And we can divide cardiotoxicities into early events, which are those that occur within the first 100 days post-transplant, and then later events, those that occur after the 100-day mark, and those may not even become apparent for many years after transplantation. Now, the early events are primarily heart failure, arrhythmias, which are abnormal heart rhythms, and pericarditis. So the incidence of an asymptomatic decrease in heart function, which is also known as the ejection fraction, is more common than appreciated clinically and may occur in up to 33% of patients. So that means that patients may not have symptoms, but if you're following their heart function via things like echocardiography, which is an ultrasound of the heart, we'll see that quite a few patients are having declines in their heart function. But fortunately, the incidence of symptomatic heart failure is less than 5%. And again, this means that most patients don't develop symptoms like shortness of breath or fluid retention as a result in this change in heart function. The risk is increased in patients who've received prior anthracycline treatment. And there was no difference in this early cardiotoxicity whether a patient had an autologous transplant or an allogeneic transplant. And it's also important to note that these early decreases are generally reversible, and they're thought to be related to the just overwhelming stress that the transplant takes on the body. Now, atrial fibrillation is a common abnormal heart rhythm that occurs quite frequently during or shortly after stem cell transplantation. Patients may experience palpitations, shortness of breath, dizziness, or no symptoms at all. For some people, atrial fibrillation can become a persistent issue and can lead to increased risk of stroke. And for others, this is just a transient phenomenon. And we're still learning about who are the ones that are going to develop a more persistent long-term problem. We know that risk factors for developing atrial fibrillation in this early period include older age, if someone has something referring to premature atrial complexes or delays in their conduction on an EKG taken before transplant, if they have pre-existing cardiovascular disease, if they have abnormal kidney function demonstrated creatinine, if their left atrium is enlarged, which is a measurement we get on the ultrasound of the heart, and pretty much everyone gets one of those before they undergo transplantation. If melphalan was part of their preconditioning chemotherapy, which is quite common in the autologous transplant groups. And then, of course, prior exposure to anthracyclines or mediastinal radiation. And finally, pericarditis. This is an inflammation of the lining around the heart. And while pericarditis itself is not dangerous, it can be quite painful and impact quality of life and the speed of recovery in that early post-transplant period. And we recently published data from our experience here at Penn. We found that the incidence of pericarditis was around 3.2%, and patients with pericarditis were more likely than patients without pericarditis to have received total body irradiation. And importantly, a medication called colchicine, which is a safe anti-inflammatory medication, was an effective intervention. And patients who received at least 90 days of colchicine had reduced recurrence of their pericarditis. Now, moving into the late cardiotoxicity, these are the things that are occurring after that 100-day mark, including many years after a person has gone through transplantation. And this includes things like heart failure, heart attacks, strokes, heart valve problems, and then something that we refer to as autonomic dysfunction, which is manifested by symptoms like fast resting heart rate, positional dizziness, and sometimes fainting. Now, we talked a bit about decreased heart function in the early transplant period, but it can also occur in a more delayed fashion. Heart muscle dysfunction was found in around 42% of survivors, of whom 28% were symptomatic. And again, this is something that can occur many years after transplant. Dysfunction was associated with age, the total dose of anthracycline, the presence of graft versus host disease, and the number of cardiovascular comorbidities at the time of transplant, things like hypertension or diabetes. Dyspnea, which is shortness of breath, is the most common presenting symptom, and this risk persists for decades. In fact, the median time to the development of problems is around 17 years post-transplantation. Now, the risk of heart attacks and strokes increases with increasing age of the person at the time of transplant. And this risk increases by more than 4 times in people with underlying cardiovascular risk factors and in those undergoing allogeneic transplant. Interestingly, neither chronic graft versus host disease nor total body irradiation are considered significant risk factors for the development of one of these arterial events. Another late cardiovascular issue that can be seen in transplant survivors is heart valve disease. This most commonly occurs in people who've received prior mantle or mediastinal radiation. However, there may also be an association with anthracycline exposure. We know that the aortic and the mitral valves are the most commonly affected because they are the ones that sit closest to the chest wall. Problems generally occur more than 10 years after treatment, and symptoms include shortness of breath, dizziness, fainting, swelling of the legs, chest pain, or fatigue. And then something that we don't talk about a lot, but is a significant problem for many people, is something referred to as autonomic dysfunction, which is a condition where the nerves that control vital functions like heart rate, blood pressure, digestion may be damaged. And in cancer patients and survivors, this is most commonly due to radiation, but can also be related to chemotherapy. And the symptoms of autonomic dysfunction include dizziness, palpitations, elevated heart rates, fatigue, weakness, and even cognitive impairment. In addition to its impact of quality of life, there may also be an association with long-term mortality. However, this has not been well established. Now, we know that certain baseline risk factors in stem cell transplant patients increases the likelihood of developing frank cardiovascular disease in the post-transplant period. Now, these include age at the time of transplant, anthracycline dose, hypertension, diabetes, smoking, and chest radiation. And if you take each of these as a potential risk factor and then create a risk score, you can see what the incidence is over 10 years. So the low-risk group had less than 3 of the risk factors that I showed you previously. And with that age group, the youngest were considered to have 1 risk factor, the in-between age was 2, and then the elderly was going to be 3 risk factors. So if a patient had less than 3 risk factors, the 10-year cumulative incidence of developing a cardiovascular event was around 3.7%. If you had 4 to 5 risk factors, the incidence was almost 10%. And if you had 6 of those risk factors, the incidence of developing heart disease was more than 26%. So with all of that being said, this information can obviously be concerning, and I suspect many of you are probably wondering, what can you do to try and reduce your risk of developing heart disease after transplantation? So of course there are some risk factors that we can't change, things like radiation or the specific chemotherapy exposure. So we want to focus on those risk factors that we know are modifiable. So when I see patients in clinic, I use something called the ABCDE approach to cardiovascular risk reduction, which is simplistic, but provides a nice and validated framework for discussion with patients. Now, these are the issues that every person should consider for good cardiovascular health, but they are even more important for cancer survivors. So A stands for the awareness of symptoms, as well as aspirin in select cases. B is for blood pressure control. C is for cholesterol control, coronary artery disease screening, and cigarette avoidance. D is for healthy dietary choices and diabetes control. And E is for echocardiogram and exercise. And I'm going to go over a few of these in a bit more detail. So the role of aspirin in primary prevention, meaning the prevention of a problem that has not yet occurred, is controversial, and it's especially controversial in women. And I'm sure many of you have heard about recent recommendations against the use of aspirin in many individuals. But we may still consider aspirin in certain high-risk cancer populations, such as those patients who had received prior radiation to the chest or perhaps to the neck, or to patients who have evidence of calcium buildup in their arteries. However, this is an area that certainly needs more data and research. Now, high blood pressure is common in stem cell transplant survivors and affects around 18% of individuals. Hypertension significantly increases the risk in cancer survivors for the development of coronary artery disease, heart failure, valvular disease, and abnormal heart rhythms. And because of this, blood pressure control is essential, and the goal blood pressure should be less than 130/80. So if your blood pressure is generally running above those numbers, regardless of what your age is, we want to try to work on getting it below 130/80 because that's been shown to reduce the risk substantially of developing things like heart attacks, strokes, heart failure. Now, if you've had radiation exposure, especially to the chest, it's reasonable to have a stress test every 5 to 10 years after exposure. For those of you that haven't had a stress test before, it involves walking on a treadmill, and then every 3 minutes, the treadmill gets a little bit faster and a little bit steeper. Now, people often ask, am I having to run from the very beginning? And the answer is no. In general, you aren't running until the 8th minute. It's really that incline in the treadmill that's causing your heart rate to increase. Your blood pressure is going to be measured periodically, and you'll be hooked up to an EKG machine throughout. And we want you to exercise until you reach at least 85% of your maximum predicted heart rate for your age. Now, if you absolutely cannot exercise for whatever the reason may be, there are other types of stress tests that use medications to provide equivalent data. We know that cholesterol abnormalities can occur even before transplantation, and that's because of the shared risk factors that often exist between the development of heart disease and cancer. But stem cell transplant survivors often experience significant metabolic abnormalities after transplantation, including hyperlipidemia, even if their pre-transplant cholesterol levels were completely normal. As you can see from this graph, the incidence increases with the duration of time post-transplant and is more common in patients who underwent allogeneic transplant compared to autologous transplant. So transplant survivors need aggressive monitoring and treatment of abnormal lipids. We generally recommend initiating a moderate intensity statin medication to lower cholesterol levels in stem cell transplant patients if they have established clinical atherosclerotic cardiovascular disease, if their LDL cholesterol is above 190, if they fall between the ages of 40 and 75 and have diabetes with an LDL between 70 and 189, or if they fall between the ages of 40 and 75, have an LDL between 70 and 189, and an estimated 10-year risk of having an atherosclerotic cardiovascular event of 7.5% or higher. And we calculate that risk using something called the pooled cohort equation, which incorporates your age, your gender, your race, cholesterol levels, your blood pressure, whether you're being treated for high blood pressure, diabetes, and smoking history, and we're able to generate what the likelihood is that you're going to have an event in those next 10 years. Now, that calculator doesn't specifically take into account cancer treatments, and so therefore we think probably for cancer survivors it might even be higher than what we're plugging into this calculator. But right now, this is the best that we have. Diet is incredibly important and is often underappreciated. We know that stem cell transplant survivors have increased rates of diabetes and obesity compared to the general population. The red line on the graph demonstrates that stem cell transplant survivors have increased rates of diabetes compared to the non-transplant patients in blue. We know that obesity increases the risk and reduces the likelihood of disease-free and overall survival amongst those diagnosed with cancer in general. And we also know that a diet higher in vegetables and fruits, as well as whole grains, has been associated with reduced mortality and less cancer recurrence. Looking at exercise, at least 20 prospective studies have shown that physically active cancer survivors have a lower risk of cancer recurrence and improved overall survival compared to those who are inactive. Exercise has been shown to improve cardiovascular fitness, muscle strength, body composition, fatigue, anxiety, depression, and overall quality of life. The current recommendations from the American Heart Association is 150 minutes per week of moderate intensity exercise, which would be something like a brisk walk, or 75 minutes per week of vigorous exercise combined with strength training. Echocardiograms are ultrasounds of the heart and tell us the strength of the heart muscle. They give us that ejection fraction measurement. A screening echocardiogram should be considered in all patients at 6 and 12 months post-transplantation. And then the medium and high-risk patients, which include those patients exposed to anthracyclines or chest radiation, or those who have multiple cardiovascular risk factors, should be considered to have additional echocardiograms every 2 to 5 years thereafter. So in summary, most patients with cardiovascular disease can safely undergo stem cell transplantation. Unique cardiovascular toxicities like arrhythmias, pericarditis, heart failure, strokes, heart attacks, and valvular disease can occur both early and late after transplant and can be related both to the transplant itself as well as to the treatments leading up to it. It's essential to focus on cardiovascular risk factor modification, and I highly recommend that you seek out cardio-oncology evaluation to ensure optimal cardiovascular health if you're a transplant survivor who has risk factors. I want to thank you so much for your time and attention today, and I'm happy to answer any questions.
Thank you, Dr. Fradley, for this excellent presentation. We will now begin the question and answer session. If you have, so the first question is, this is about blood clots. I am 5 years post-transplant and recently started to develop arterial blood clots in my legs. My doctors don't know why I'm getting them. Are patients who have had a transplant more prone to blood clots, and is it related to the heart?
That's a really good question. So two parts of that. There's blood clots can either occur in the veins. Those are sort of the more common blood clots that we think of. Those are the ones, people may experience if they were on a long airplane ride. And those are the ones that could then move to the lungs and cause what's called a pulmonary embolus. And then there are the blood clots that form in the arteries. And those are more unusual, but we do think that there is some effect to the arterial tissue from transplant. And that's one of the reasons why we see over time increased rates of heart attacks and strokes, because those are also blood clots in arteries, the coronary artery, or one of the arteries that go to the brain. So similarly, people can develop blood clots in the arteries to their legs, and there's likely a complication or a long-term cardiovascular complication related to transplant.
Thank you. The next person writes, I am a 10-year allo stem cell survivor with a family history of cardiac disease. Is it wise for me to get a baseline test and establish a relationship with a cardiologist, even though I'm not having any cardiac symptoms? My blood pressure and heart rate are low to normal.
Yeah, I think that that's something that would be very reasonable for you to do, especially even more so depending on what treatments you may have received prior to your transplant. And as I talked a little bit about things like anthracyclines and radiation, but there really are quite a lot of medications that people have received that may have some long-term risk. And then when you combine the fact that you have a strong family history, I think absolutely getting a baseline evaluation is appropriate and reasonable. And I see many patients just like yourself who come in for, sort of that risk factor assessment. I think, what would be really beneficial for you is that if you can find a person where you live or somewhat close by who does have some expertise in this field of cardio-oncology, because that person will sort of understand a bit better the nuances and your risk a little bit better. Sometimes if you see just a regular cardiologist, that person may not be as familiar with what your risk is, and they may not be as aware of the things that must be monitored in a person like yourself. So if you have access to someone with the more cardio-oncology expertise, I think that would really be the most beneficial for you in terms of evaluation.
Thank you, doctor. Good advice. Now, we've been talking about stem cell transplants, and this person is asking, are the risks the same if you've had a bone marrow transplant?
Yes, and potentially even higher if you had sort of the bone marrow transplant, simply because of some of the treatments that go into bone marrow transplant may even have a slightly higher toxicity, but treat the two as essentially the same in terms of what we need to look out for.
Okay, thank you. Is there data available on CAR T-cell therapy and cardiovascular issues?
There are data, and we're still learning more and more about CAR T. Right now, the information that we have is predominantly in the early period of CAR T therapy, and it's usually in the setting of the cytokine release syndrome. So in patients that are experiencing significant CRS or cytokine release syndrome, we do see various cardiovascular issues like abnormal heart rhythms. We can see heart failure. We've even had patients who've had sudden cardiac death as a result of this severe inflammatory response. Excuse me. What we don't know is if there are long-term effects, and that's something that we are certainly very interested in, as there are longer-term survivors who've received CAR T to see if there are long-term effects. But what we're at least seeing in the short term is that if a problem happens, it usually happens in the setting of that CRS, and then in the majority of cases, they resolve as the CRS resolves.
Okay, good to hear. The next person asks, what is LVEF?
So LVEF stands for left ventricular ejection fraction, or sometimes you'll see just EF written, which is ejection fraction. And that's the medical terminology for the heart function, so how well the heart is squeezing. And a normal ejection fraction, or EF, is between 50 and 70%. So no person is ever at 100% at any time in their life. But that's essentially when we're talking about the strength of the heart, we talk about it as the ejection fraction, or EF.
Great, thank you. And when is low blood pressure a problem?
It depends. In general, low blood pressure is a problem if it's causing somebody symptoms. So when it comes to high blood pressure, we know that there is sort of an absolute cutoff that above which your risk starts increasing for cardiovascular disease. But for lower blood pressure, in general, it has predominantly to do with symptoms. Now, there are some people who have looked at what's called a U-shaped curve of blood pressure, that as you start getting lower and lower, you have increased overall risk. And some of that has to do with the fact that as people's blood pressure gets lower, it's often, when it's evaluated, it may be in the setting of someone who's very sick. Maybe they're infected, maybe they get dizzy and they fall and they injure themselves. But really, it's a lot about the individual and how they feel. There are people who have blood pressures, the top number being in the 90s, and feel perfectly fine, and that's just normal for them. And there's no worry or risk or concern if that's the case. On another hand, another person may have a blood pressure in the 90s, and they feel really tired and they feel dizzy. And in that case, we have to do something about it to try to get them to feel better.
Okay. The next person writes, the day I left the hospital for my second BMT, I had atrial tachycardia and had to have electrocardioversion. Was this most likely due to the melphalan? Does it need further follow-up? I'm now 6 months post-BMT, and it has not been a problem.
I'm sorry. I would say most likely it is related if you receive the melphalan as part of the preconditioning. We know that anywhere between about 10 and 15% of patients who get exposed to melphalan will have an atrial arrhythmia at some point in the peri-transplant period. Generally, the median time to developing it after transplant is around 15 days. So that's probably the explanation. The second question that you asked is a more challenging one, because we aren't really sure if a person develops atrial fibrillation or an atrial arrhythmia in the setting of transplant, if that translates into long-term risk of recurrence. So if a person were to come into my clinic, just, came in one day and said, hey, I was, at my regular doctor's office and they noted my heart was irregular and told me I was in atrial fibrillation. At that point, we consider the person to have AFib. Even if they go in and out of it, this is a problem for life. What we're not sure about is whether or not that same problem for life exists if the person develops it in the transplant period and had this provocation as it relates to the melphalan. And that is actually something that we're actively looking at in our transplant population here at Penn, where we're actually following patients after transplant who've developed atrial fibrillation. We're monitoring them with a little subcutaneous monitor, so little monitors under the skin that allows us to check their rhythm 24/7 and see if they're having recurrences. And then that gives us good information about whether or not we need to institute additional medications in the long term for their overall health. And that's important because if someone is having recurrent atrial fibrillation, it could increase their risk of having a stroke in the future. So I think to kind of sum up your question, if you're not having follow-up with a cardiologist, cardio-oncologist, I think it's a good idea for you to, so that someone is at least thinking about the possibility of recurrences.
Thank you. Will CAR-T affect AFib?
It can, absolutely. Again, in large part because the CRS and the inflammatory state that can occur can definitely sort of flare up someone's atrial fibrillation.
Okay, thank you. What is high adriamycin? I'm a 30-year survivor of an autologous BMT for breast cancer and was given that chemotherapy.
So the ASCO, or American Society of Clinical Oncology, suggests that a high-risk individual is somebody who's received more than 250 milligrams per meter squared of doxorubicin or its equivalent. Breast cancer regimens currently are generally 240. Hodgkin's lymphoma regimens are usually around the 300 mark. Older breast cancer regimens, so perhaps the time that you were treated, you may have received higher doses at that point in time.
Person's low blood pressure be caused by GVHD. Their blood pressure is in the range of 100 to 120 over 48 to 52, and the person is 7 years post-transplant, relapsed at 7 years post-transplant for AML, and the AML is currently in remission. They are not on any immunosuppressants.
Got it. I would say that it's possible, but certainly not definitively associated.
Okay, thank you. Does the allogeneic transplant process, i.e. the preconditioning, the full body radiation, cause damage to arteries, decreasing the flexibility and increasing blood pressure?
It can, absolutely. And then we definitely know radiation does has a lot of adverse effects to the vasculature. So it can affect the distensibility of them, and it can lead to some blood pressure effects. It can also just affect the integrity of those vessels, which is why we think there's an increased likelihood of thrombotic events, heart attacks, and strokes.
Okay. My previous LDL before transplant was 100. I am 14 months past, and LDL is 176. When should I be treated with medicine to bring it down? And maybe you can make a few general comments about this also for the general population.
Yeah, so your experience is not unusual at all. This, kind of dramatic change from a pre-transplant LDL to a post-transplant LDL. And again, I think, we're still trying to understand exactly what and why transplant has these effects on the metabolism so much. In general, there are various aspects that kind of help guide our decision making to start statin therapy. Certainly, cholesterol levels above 160, we really start to get more, a bit more concerned about the need to initiate a statin. And certainly if someone's above 190, then the answer is absolutely. When someone falls into that intermediate range, say less than 190 but still high, that's where the ABCDE calculator can be very helpful. And that's where we start looking at aspects like your age, your gender, what your actual numbers are. What is your actual blood pressure number? What are some of the medications you're taking? And this allows us, once we have all this information, we can plug it into a calculator, and then we can estimate your risk for a problem in the next 10 years. And if you hit a certain percentage, that number 7.5%, that's when we say a statin is absolutely necessary. Now, there are some other things that we could look for in addition to that. Sometimes if that number's lower, I'll look on a CT scan and look to see if you have any calcium deposition in any of your arteries. If you do have calcium deposition, then again, that suggests a higher risk individual and someone that we would want to get started on a statin in order to try to prevent future events. So I would definitely recommend in your case, it's highly likely you'll need to be started on a statin medication, but first I think it's really important to, again, meet with somebody who kind of understands this risk and, looks through your various specific and unique history and kind of comes up with the best strategy for you as an individual.
Thank you. Does an asparaginase-induced stroke predict future issues?
Not necessarily. That's sort of its own sort of unique type of stroke, so it doesn't necessarily suggest increase, in the types of strokes that we typically think about, either in the post-transplant period or just sort of in the general population that you'd think of as sort of a typical stroke.
Thank you. My aortic valve is leaking steadily at 10 to 20%. My cardiologist is waiting and watching. Is my only option open heart valve repair down the road?
Unfortunately, at this time, the answer to that is yes. For leaky aortic valves, we don't yet have less invasive options than open heart surgery. Now, for valves that become stenotic or narrow valves, then those cases we have some of these non-invasive management strategies. But for leaky valves at the moment, at least leaky aortic valves at the moment, that's our only real option.
Okay. Is it normal after a BMT to have random episodes of racing heartbeat? I had scans done and nothing shows up.
Yes, I would say that it actually is probably a lot more common than people recognize and acknowledge. This goes back to that topic of autonomic dysfunction that I spoke briefly about. We don't fully understand what and why autonomic dysfunction occurs, but essentially, the way I explain it to patients is just like you're told that you can develop a peripheral neuropathy related to some chemotherapy, where they'll tell you, you might develop, pain and numbness and tingling in your hands or your feet. Well, the same thing can happen to the nerves that control these more classic homeostatic functions, like heart rate control or blood pressure control. So people oftentimes will start telling you after they've had these various treatments and exposures that they do have, palpitations, heart rate elevations for no particular reason, wide swings in their blood pressure. And, it's not that the heart is dysfunctional, but it's that the heart is responding to the signals it's being told. It's just those signals are wrong. And it can be really problematic and really impact people's quality of life. And our job is to try to help manage the symptoms as best as we possibly can. And there's a lot of things that can cause autonomic dysfunction in individuals, even outside of the transplant world. Many of you've probably heard of long haulers syndrome as it relates to COVID-19 infection. Well, a lot of the symptoms that people have in the long haulers are things like racing heart sensations and blood pressure variations, and we think it's the same thing, and in that case, it's the virus that is damaging those nerves. So your symptoms are something that a lot of people experience and are probably under-recognized.
Okay. Can immunosuppressant drugs increase blood pressure?
Some can, for sure. For example, cyclosporin can definitely increase blood pressure.
Okay. Would you recommend a cardio-oncologist versus a regular cardiologist for prostate cancer survivor experiencing AFib?
I think that a cardio-oncologist, if you have one available, is always going to be an ideal physician for you to connect with, because they understand some of the complexities of the treatments, the potential interactions of the treatments with other drugs that we may offer from the cardiology standpoint. There may not be as many options available due to drug-drug interactions, and just sort of understand sort of the overall interplay of cancer and cardiovascular disease. Now, I say that recognizing that there are a lot of people out there that are not necessarily in an environment where they have someone who specializes in this field. And so certainly general cardiologists are capable of managing these issues, but I think that the cardio-oncologist kind of just gives you a different approach and perspective about the conditions that you're experiencing and has that more subtle understanding of the overlap between the two conditions.
Okay. Does long-term tacrolimus use provide any risk to having future cardiac complications in a young, previously heart-healthy patient?
Not generally. I mean, certainly tacrolimus could create some kidney issues, and then that could lead to blood pressure issues down the road. But we use that drug quite a bit in people who've had heart transplants as well to prevent rejection, and that doesn't necessarily lead to additional or new cardiac problems for their transplanted heart.
Thank you. The next question, how does pericardial effusion affect or predict cardiovascular issues?
In general, pericardial effusions themselves do not necessarily predict any sort of long-term cardiovascular risk or toxicity. So they tend to be sort of their own unique, isolated problem that's usually indicative of some other issue. So, a malignant effusion. So a person develops the fluid around the heart because of, the cancer itself, or they had a viral infection, or they, develop this sort of systemic inflammatory response where they develop swelling and fluid buildup in, various areas of their body. Probably the biggest association between a pericardial effusion and another cardiovascular event is the development of pericarditis, which is that inflammation of the lining that can be very painful for patients, a lot of really bad chest pain as a result of it. But it doesn't necessarily increase risk of future heart attacks, strokes, heart failure, or anything like that.
Thank you. For a few days after conditioning, I had a very high heart rate, 150 resting. Would this have caused lasting damage or have just been a temporary reaction to the chemo?
Yeah, in general, if it's temporary, it does not create lasting damage, and especially if it's the normal rhythm, that doesn't seem to ever really cause lasting damage, even for people that are in a fast heart rate for a very persistent and long period of time. Now, certainly if somebody is in an abnormal rhythm and they're fast for very long periods of time, that could potentially create long-term problems. But if it was transient, as you suggest, then it shouldn't lead to any long-term issue.
Good news. Thank you. Have you seen any patients that have experienced a numbness along the path where their PICC line was? Would you consider this neurological issue or a cardiological issue?
Certainly not something that I have necessarily personally encountered, but I would definitely say that, based on the description with the numbness, it sounds more like that is, potentially neurological, just from where they make the incisions of the port and stuff, there might be, damage from the nerves, and as they kind of regrow, it could create some of those problems. So I would say that it sounds more neurologic, but it's not something that I've personally encountered.
Okay. Are there genetic tests for cardiovascular risks?
There are. A little bit depends upon, the individual and what we're looking for. We certainly don't, do genetic screens just in, without some sort of, without, we don't just cast a broad net and, see what happens. We need to sort of have a little bit of a focused approach. And so certainly if somebody, let's say, has a strong family history of certain conditions, then we might think about specific genetic tests that we want to consider. Similarly, if somebody's cholesterol is quite elevated, we may want to send some specific genetic tests to see if they have a familial hypercholesterolemia syndrome. So we kind of base the decision on, on other symptoms, family history, et cetera. We don't just sort of automatically test for genetic syndromes, but we certainly can depending on the situation.
Okay, thank you. Okay, this one is pretty specific, but I think if you could shed some light on it, it would be helpful. This person had an auto transplant February 10th of this year, and they've had strange symptoms since his myeloma treatment. It happened more on Revlimid, but it has been, but she's been off it since January. She hadn't had the symptoms in about a year, but had it several days ago. It happens at rest. It starts in my nose and mouth with strong burning in my tongue and mouth and inner jaws, then starts in my chest, ribs, and through my back. It is always at rest and lasts 20 to 25 minutes. I had an echo and an EKG prior to stem cell, and no issues were found. I do walk a lot and use an exercise bike, and no symptoms with exercise. It just happens occasionally.
Yeah, I mean, I don't have a great explanation for what you're experiencing. I think certainly the echo and the EKG is a good first step, but I think it probably warrants some additional evaluation from a cardiologist.
Thank you. What can a post-transplant patient do to help minimize ongoing congestive heart failure?
Well, I think number one is make sure that you are regularly seeing a cardiologist, ideally a cardio-oncologist. There are various medications that can be given to try to improve symptoms and potentially even improve heart function. So making sure that your doctor has kind of thought through, whether those are medications that are needed. And really kind of following those ABCDEs that I had suggested. Now, if somebody is at risk for dysfunction but has, like, for example, they've received the treatments but don't actually have any symptoms yet or don't have any cardiovascular dysfunction, those ABCDEs become even more important because it's really those that if we can manage and alter those risk factors, then hopefully we can prevent the development of a problem down the road.
Thank you, Dr. Fradley. That was our last question. So I'd like to thank Dr. Fradley for this excellent presentation. We will now, on behalf of BMT Infinite and our partners, I'd like to say thank you to the audience also for your excellent questions. Please contact BMT Infinite if we can help you in any way, and enjoy the rest of the symposium.